Now I have the honor to present Dr. Victoria Delgado from Sweden. She is a She's a board-certified cardiologist. She's the assistant professor of cardiology at Leiden University Medical Center. She's one of the experts in the field of multidisciplinary imaging, and she's a board member of the ICAVI. She's going to talk about the echocardiographic guidance before, during, and after TAVR. Please go on.
Thank you very much for the kind invitation to participate in these updates. Indeed, I still remember the meeting in 2019 where we had a meeting in person, and I really enjoyed very much your meeting, and I learned a lot. And I'm not from Sweden, I'm from Spain, and I'm already since 11 months back in my hometown in Barcelona, in Hospital University Germans Trias i Pujol. So these are my disclosures. So in terms of the use of echocardiography in TAVR, I will give you an update of how most of us use it recently. But I will also highlight these new metrics that come from the United States, where they have a little bit different guidelines than what we have for ESC. And you can see that over the years, there has been a tremendous increase of the use of transcatheter aortic valve replacement, particularly in patients older than 80 years old. But also you can see here between 65 and 80, which exceeds very much the number of surgical aortic valve replacements that are being performed. But it's also striking the 50% of the patients that are younger than 65 being treated with TAVR. There are several issues and a lot of controversy to treat younger patients with a biological valve, particularly this type of valves where the risk of having a valve-in-valve is increasing, and we don't know what are the outcomes of a valve-in-valve. But also valve-in-valve is a little bit higher risk procedure than a valve in a native valve, and also if the patient needs surgery, the surgeons currently are not so well trained to perform an aortic root replacement that sometimes needs to be performed. But these are the current numbers that we see in the United States, and I think that in some countries in Europe, like in Germany, it could be around the same, not in Spain. So what do we need to do in terms of selecting and planning the procedure and how we are going to use echocardiography? We need to confirm the severity of aortic stenosis. We need to know the anatomy and the morphology of the aortic valve, select the prosthesis size, and select the procedural approach. And in terms of the severity of aortic stenosis, you all know which are the criteria that define severe aortic stenosis, which is a peak jet velocity of at least 4 meters per second, a mean gradient above 40, an aortic valve area below 1 square centimeters, and index below 0.6. But there are several difficulties when we calculate, for example, aortic valve area, and it depends very much on how we introduce the diameter of the left ventricular outflow tract. The aortic valve area can change significantly. And this is mainly because we are most of the times measuring the LVOT in two-dimensional echocardiography, and we don't realize that actually the LVOT is rather small in the anterior-posterior position, like would be this one, but it can be more oval-shaped, and then we can have a much larger annulus. And this is why probably if we introduce three-dimensional echocardiography measuring the cross-sectional area of the LVOT, we may have a much more accurate measurement of the aortic valve area. The same LVOT or aortic annulus will be very helpful in order to select the prosthesis size, whether there is a balloon expandable or a self-expandable. And we know that measuring the aortic annulus accurately minimizes the risk of paravalvular aortic regurgitation, minimize the risk of prosthesis migration that sometimes can happen, but also very important, minimize the risk of annular rupture, and that can happen particularly when we use a balloon expandable valve. The way of measuring, there has been a lot of discussion. Actually, there are many imaging techniques that we could use. Initially, even was performed with angiography, getting two perpendicular views of the fluoro. Then we have transthoracic or transesophageal echocardiography, doing 3D transesophageal echocardiography, and probably the most frequent one used right now is computed tomography. Why? Because computed tomography gives a very good spatial resolution and also can evaluate the size of the femoral arteries, which is the procedural approach that is recommended. Again, as I said before, using three-dimensional echocardiography, we can delineate perfectly the diameter and the perimeter and area of the aortic annulus, which has been compared in multiple studies against CT, and where we have seen that using 3D echocardiography, particularly when it's transesophageal, the agreement with CT is rather good than when we are using 2D echocardiography. And we know that in principle, when we use 3D echocardiography, some groups, particularly those that use much more CT, they have said that there is higher risk of regurgitation, but in expert hands, it's not true. Three-dimensional echocardiography can also measure the aortic annulus and can give you a good estimate to select the prosthesis size, particularly in patients who have renal impairment and in whom a CT can increase the procedural risk just before you are damaging the kidneys. Then it comes the question, when we perform the procedure, whether there is a paravalvular leak. And most of the times right now, when we measure with the CT, when we select a balloon expandable valve, but also a self-expandable valve, the technique has improved so much that the risk of paravalvular regurgitation is very low. And most of the times, the echocardiographer has been displaced from the cath lab, and it has been eliminated from the cath lab. So we don't perform that much transesophageal echocardiography. Actually, we sometimes don't go. It's the interventionalist, the one that does the transthoracic echocardiography. But as you can see, the image quality is not the same. And when we have, with fluoroscopy, that is frequently the way it's done nowadays, but we don't see paravalvular leak. If we see it, the question that it comes is the leak central or is paravalvular? Like, for example, you can see here with two jets, completely paravalvular. And in that case, fluoroscopy is not going to help us, it's going to be echocardiography. In this case, with these three paravalvular jets, as you can see here from transgastric view, once we reballoon, it almost disappeared, being minimal. So we can have a suboptimal result being converted to an optimal result. And sometimes it's central, like in this case, it's less frequently, but sometimes it could happen that one of the leaflets gets frozen. And in that case, the patient can get hemodynamically very unstable, and a fast reaction needs to be done. And in that case, for example, is to put a valve in order to make sure that there is a good sealing of annulus and there is a good deployment of the leaflets. Another complication that can happen is, for example, mitral regurgitation. And in this case, is not that much related to an injury of the mitral valve. It's rather difficult to damage it. But for example, sometimes patients that have a right bundle branch block or an atrial fibrillation, any conduction disturbance at baseline, by dilating the annulus or by implanting the prosthesis, you can create an AV block, or you can create even a left bundle branch block, and in that case, it can increase the mitral regurgitation, and this needs to be monitored before the patient is discharged home. Other complications that we may face is, for example, stroke. most of the times it has been thought that is related to the debris or the calcium of the aortic valve, but we don't have to forget that these patients may be in atrial fibrillation, the anticoagulation regime may be suboptimal, and if we do a transesophageal echocardiography, we may see even that there is an important sludge smoke in the left atrial appendage, which is the precursor of a thrombus and a risk of embolism. We can have also the plaques in the aorta. These patients are old, they have atherosclerosis, and with the manipulation of the catheters, we may break those plaques and complicate them that can later on embolize and create complications. And as I said before, one of the most feared complications is the annular rupture, as you can see here in this angiography. And with a huge tamponade in a patient that has a severe aortic stenosis with very thickened ventricle that is going to be collapsed and needs surgical intervention quite fast with a very bad prognosis. Then in terms of approach selection, the procedure should be performed transfemorally. Transapical, it has been abandoned. Why? Because it was associated with a higher mortality, most probably related as well to the characteristics of the patient, because the patients that have peripheral artery disease are patients that usually are sicker. But in this case, CT is going to be the technique of choice to evaluate the femoral access, because we are going to see whether there is a lot of calcification in the femoral artery or not, if they are tortuous or not, and if there is also enough caliper, enough lumen. While the echocardiography transesophageal is not going to give us that view. And in the case of the if we use, for example, a subclavian or a carotid, we need to consider whether we are going to implant protection devices for embolism, because it's more catheter that we are introducing and we need to have a good access. Perhaps the most important thing or role for the ultrasound is when we perform the puncture of the femoral arteries. And it has been shown that when the puncture is performed under ultrasonography, the risk of complications is much lower than if we perform with fluoroscopy. And here we can put the transducer along the vessel, where we will see the needle advancing and we will see that this goes in the right direction. But most operators prefer to put the transducer in a way that we can see the cross-sectional axis of the artery, because we can see better how it's entering, that we are really in the center of the lumen and we are not going too much to the sides. There has been a meta-analysis recently published showing that actually performing the puncture with guidance with ultrasound is associated with less vascular complications and also with less bleeding. And this is why most of the operators prefer to perform the access of transfemoral with guidance of ultrasound, which is also an important tool to have at the cath lab. So in conclusion, I think that echocardiography is the imaging technique of first choice to evaluate the patient with aortic stenosis, to assess the severity, to assess the anatomy for bicuspid and tricuspid, of course, that we are going to do it with echocardiography, to measure the annulus and select the prosthesis size that is more cumbersome, but still you can perform it if the window is good. And to evaluate the thoracic aorta and guide manipulation of catheters is less frequently, and for puncture, ultrasound guided transfemoral access is very important. And then for the procedure itself, most of the times it's going to be guided by fluoroscopy, but the evaluation of the results, particularly for paravalvular regurgitation, a transthoracic echocardiography is key. And I think also to evaluate any other complications that can happen. And with this, I will be happy to answer any question you may have. Thank you very much for your attention.
Thank you very much. We enjoyed your talk. It was very elaborate and very precise. I would like to ask something, please. Do you do every patient transesophageal echo on the assumption that he might develop stroke if, to avoid the stroke which happens?
Yeah, so that is a very good question. And indeed, there are the protection devices that have not shown a really benefit. Why? I don't know, because there are many other factors that may influence the occurrence of a stroke. But particularly in patients who have very large atria and who have atrial fibrillation and not a very good monitoring of the anticoagulation, a transesophageal echocardiography would not be a bad option to see the risk of stroke, particularly big emboli. Then for the atheromatosis or atherosclerosis in the aorta and the risk of complicated plaques, you could see with echo what we show. If that relates later on to big strokes, we have not seen it to embolic to the kidneys. So far, we have not seen it either. So it's something that we are there performing, but because we have been removed from the cath lab to do this procedure and to be more minimally invasive as should be, and I think that is correct, we don't see it anymore. So we try to optimize the resources and to minimize the number of people that are at the cath lab, which I think makes it more pleasant even for the patient because there is less noise, is more calm everything, because we do it also under conscious sedation. We don't intubate anymore.
Yeah, but we for our part, we have in our cath lab, the transesophageal is built into the machine. So we can just do it when the patient is sleeping. We can do the transesophageal. Do you recommend to do something like this? Because not every patient, we know that he's in atrial fibrillation. He might be in paroxysmal AF and we don't know. I'm just giving an assumption. I'm not sure whether this is too much resources consumption or not.
As I tell you, in principle, we don't do, and even if you do a CT for these patients, you will see whether there is a lot of smoke or there is a defect of replacement, for example, of the appendage on CT. So there you can see whether there is the risk of thrombus or not, and then if you have a doubt, you can select the patient in whom you will perform a transesophageal. Not every patient needs to have a transesophageal. But the idea of my talk is more or less to show you that echocardiography is not completely abandoned on TAVI. You have many resources to use according to the question that you want to answer, and if after that is going to be an action to perform. So there are some places where they say CT is a must. I may agree, but it's not always. It depends on the clinical situation of the patient.
Thank you so much, Victoria, for this wonderful presentation. We have here many friends that you know them very well, and Tariq Kafafi and Mohammed Abdel Ghani, and they would like to ask you questions. Tariq.
Hi, Victoria. It's Tariq Ahmed.
Hello, Tariq.
Hello. I have some questions, maybe a couple of questions. The first one regarding back in time in Leiden, they used to do routine pre-dilatation with balloons. How often did the balloon sizing, which was guided in that time by transesophageal echo, how often did this change your decision about the valve size compared to CT? That's the first question. The second question is regarding the CT follow-up for patients after valve implantation. Do you recommend this doing it routinely, or should it be selectively in specific population, depending on the annulus size, bicuspid morphology? I'd like to hear your opinion about that. And wishing to see you in person on the next occasion.
Thank you very much, Tarek, for the excellent questions, and really looking forward to see you again in person. So for the first question, in Leiden, initially, like in many places, we were doing the procedure with transesophageal echocardiography. We were not, I don't think that we ever changed the size of the prosthesis based on the balloon dilatation. we had luckily the CT and otherwise the 3D transesophageal echocardiography. But we were not relying on the balloon inflation. Then for the second question, the CT, again, I don't think it's needed systematically. Systematically, it's needed an echocardiography and speaking to the patient and listening to the patient. Because if there is any change in the symptomatology of the patient, if there is any change in the function of the ventricle or in the gradients or on the aspect of the prosthesis, then you will need to have a CT to see further the type of degeneration of the prosthesis, if there is any suspicion. These patients right now, the main risks for discharge are breathing disturbances, because we tend to do the procedure less and less invasive and try to discharge the patient the day after if possible. But there is sometimes that there is the risk of having conduction abnormalities that do not appear immediately but appear 1 week later. And these are elderly patients that may live alone, and that is a big risk. And the risk that, for example, these patients develop, as I said, conduction abnormalities that need pacemaker and may impact on the recovery of the function of the ventricle or induce mitral regurgitation or other complications. I think that the follow-up with echocardiography is mandatory, the follow-up with CT no.
Thank you very much, Dr. Delgado, for a very comprehensive presentation. And I'm wishing you all the best for your upcoming career endeavors after very fruitful years in Leiden. I have a question regarding the role of 3D echo in TAVI planning, because I'm a TAVI operator, and one of my very challenging situations that I am encountered with is a patient with severe CKD, uncontrolled atrial fibrillation, who is dyspneic, and I cannot perform CT angiography, and I actually usually I don't dare to take the patient to the cath lab without having a CT measurement of the annulus. Of course, echo may play a role. 2D is out of question because it will systematically underestimate the annular size, but in your opinion, the contemporary 3D technology, can it replace CT? Is it reliable in annular sizing in patients in whom we cannot perform CT angiography?
Yes, I've done it. And particularly, for example, patients who are in a very poor condition, like in cardiogenic shock, for example, that they have a renal function that is with an eGFR of 30, that you know that they are hypoperfused, and the administration of contrast is going to kill the kidneys and increase the risk of recovery for that patient. I would do a transesophageal without any doubt.
Any other questions from the floor? So, Professor Victoria Delgado, thank you so much on behalf of the Egyptian Society of Cardiology. I'd like to thank you, and we are delighted that you joined us today in Cardiology Updates. And we are looking forward to seeing you in Cardio Egypt in next February. So
thank
see
you so
soon.
much, Marty, and to the entire Egyptian Cardiac Society. It's always a pleasure, and I wish you all the best and enjoy very much your meeting update. Really, always very insightful. Congratulations.
Thank you. Have a good day. Bye-bye.
Have a good day. Bye-bye.
Bye-bye.
Now I have the honor to introduce Dr. Hatem Seliman. He is a consultant cardiothoracic intensivist in Harvard Hospital, London. And he will talk about lung ultrasonography in 2022.
حاتم بنرحب بيك وسعداء ان انت معانا النهارده. يعني شكرا على ان انت accepted the invitation to join us في الكارديولوجي ابديتس. ودايما انت الحقيقه يعني معانا في كل ال educational activities. فبنشكرك شكرا جزيلا.
شكرا جزيلا Professor Magdi. Thank you very much, dear professors. It's a great honor to be with you in this Congress, and as always, I'm very honored and delighted to be with you. And I'm going to give a brief presentation to discuss where we are with the role of lung ultrasound in managing cardiac patients. So historically, the lungs were considered a major hindrance to the use of ultrasound for an obvious reason, because the lungs are normally aerated. So the air is an enemy of ultrasound, and that's what made Professor Harrison, in his famous textbook of internal medicine in the 1990s, to say that lungs are not suitable for ultrasound. It was quite a strong and explicit statement, which ironically proved not entirely accurate, because around the same year, the first seminal paper of Professor Denis Lichtenstein, a French anesthetist, was published, which described the analysis of the different artifacts generated by the lungs when scanning them with ultrasound. And if you go on PubMed and try to use the keywords lung ultrasound, you will see the exponential explosion in the number of publications over the years. And we are seeing a growing increase and growing interest in research and education in lung ultrasound, especially in the field of cardiology and especially in the field of heart failure. So I will briefly go through an overview of lung ultrasound for those of you who did not have a chance to go into the modality. So it relies on the usual principles of ultrasound, that it is not transmitted through air. The normal parenchyma is not visible. The interface between the pleura and the lung is the interface that reflects the ultrasound beam. And our acoustic window for scanning is the intercostal space. And there are numerous advantages. Time will not be enough to go through all of them, but it's immediately available, repeatable. It is rapidly applied at the point of care. It is easy to learn with a steep learning curve. It reduces cost, because now we have many data which prove that lung ultrasound is far superior in sensitivity and specificity compared to chest X-ray. Therefore, it reduces risk of radiation exposure and also potentially reduce cost. So the requirements for performing lung ultrasound, there are depending on what we are looking at. So if we are looking at the parenchymal assessment, we can use exactly the same probe we use for cardiac ultrasound, the phased array transducer, because we need a probe with a deep penetration, and that's the phased array low frequency probe. If you have a curvilinear abdominal probe, it can also be equally used, and some recommend that it is preferable to the phased array transducer, but I can say that phased array cardiac probe is totally acceptable, and I encourage you to perform lung ultrasound as part of your routine echocardiographic examination. If you are looking at the lungs, pleura, which are superficial structures, you need to use the high frequency linear probe, and that's a different part of the assessment. And then once knowing what probe you can use, you need to put a systematic approach for performing the examination. And that systematic approach will be determined by the clinical context. If you're examining patient in an outpatient clinic, you have time to go through different zones in the lungs. So that's one of the validated protocols, which looked at dividing each lung into 6 zones, 2 anterior, 2 lateral, and 2 posterior. But if you are working in acute cardiac care, emergency department, critical care, you don't have much time with the patient, then it is advisable that you only go for 3 zones on each lung, 2 anterior and 1 lateral posterior. And then putting the probe on the lungs will depend on what pathologies you are looking at. If you are looking at pneumothorax, then you need to look at the pleura with a linear high-frequency probe, putting the probe, as you could see at the top image, in the mid-clavicular line with the probe orientation marker towards the patient's head at the second intercostal space. And if you're looking at signs of lung congestion in the context of heart failure, you need to do a systematic examination, but focus on the anterior and dependent zones. And if you are looking at pleural effusion, the example here is the lower image on the screen, where you have the phased array or curvilinear transducer put at the mid-axillary line with the orientation marker towards the patient head. So let's go through the artifact briefly. This is the normal artifact that you first see when you put your linear probe at the second intercostal space, mid-clavicular line. You are seeing here the 2 black rib shadows, and you are seeing the brightest white horizontal line which is the pleural line, and that is connecting both rib shadows together. And this is the first initial sign, which is described at the bat sign. And that's absolutely normal. And then when you rotate the probe 90 degrees to align your beam and probe with the intercostal space, this is the normal artifact you see in the presence of dry lungs or in the absence of pulmonary congestion, and that is described as A lines. And A stands for aeration. So these are horizontal reverberation artifacts of the pleural line. So they are not true anatomical structures, and they are extremely sensitive in ruling out pulmonary congestion. But remember that it can also be seen in pneumothorax. And when you start to see early signs of congestion, very, very early signs of congestion, far early before symptoms, before desaturation, before X-ray findings, you start to see these vertical comet tails or vertical laser-like beams starting from the pleural line and going all the way to the far field. And those are described as the B lines. And these are important sonographic biomarkers of lung edema or lung water. And this is different examples of normal B lines on your left-hand side, where you can only see up to 2 distinctive isolated B lines in one intercostal space, and the abnormal B lines where there are more than 2 isolated B lines in one intercostal space. And one of the very important concepts about lung ultrasound is utilizing it as a monitor to assess the changes in aeration in the lungs in the context of heart failure, and also in the context of pneumonia and non-cardiogenic pulmonary edema, because both clinical situations will cause lung edema, one due to hydrostatic pressure elevation, and one due to inflammation and capillary leak. And here you could see the spectrum of change in aeration. From the top, you are seeing A lines, normal aeration, reduced aeration with appearance of the vertical B lines, and even complete loss of aeration in the context of pneumonia and ARDS, when the lung becomes anatomically fully exposed in the context of consolidation. And you could see here the power of lung ultrasound as a monitor to assess the change of aeration from loss of aeration to restoration of aeration. And there are many data, actually, it's beyond the time limit of the presentation, but there are many, many data which proved the reliability of lung ultrasound in assessing, in monitoring, in prognosticating, and evaluating the outcome of heart failure patients. And that's one of the studies which looked at 100 patients in ambulatory heart failure patients to evaluate pulmonary congestion, and they found that lung ultrasound was far superior to the standard validated clinical congestion score, which was quite insightful. And they found that the cutoff value for B lines was 15 or more B lines to be considered a quick and reliable assessment of decompensation. It can also be used in triaging patients and risk stratification. The more the number of B lines, the higher the risk of the patients, which requires immediate attention and adjustment of therapies. And the increasing robustness of data available in lung ultrasound enabled the European Society of Cardiology to introduce B lines as part of the assessment of heart failure patients. And now the European Association of Cardiovascular Imaging is preparing the first consensus document on the value of assessment of the lungs with lung ultrasound in heart failure patients. And actually, there are many data, and just for the sake of time, I will quickly go through them. This is another study which looked at the prognostic value of lung ultrasound in hospitalized patients for heart failure, irrespective of symptoms and ejection fraction. So it's not only heart failure with reduced ejection fraction, but also heart failure with preserved ejection fraction. Any patient who could develop signs of pulmonary congestion can be precisely assessed with lung ultrasound. And this is an example of that B lines are not only valuable in heart failure, but also valuable in pneumonia. As I mentioned, it is valuable in patients with renal failure on dialysis by assessing the efficacy of dialysis and fluid removal. And in COVID-19, there was an exponential increase in the utilization of lung ultrasound because it is safe. It was less risky to spread infection between the radiographer coming to the units for repeated X-rays. And as I said, it is far more sensitive and specific than chest X-ray. And this is a study that we published during the pandemic, which looked at correlating the lung ultrasound findings in patients with COVID-19 to the appearance on CT scan. And the ground glass opacification on CT, which was one of the distinctive frequently seen features on COVID, was well correlated to the appearance of patchy coalescent B lines in the context of patients with COVID-19 who known to have asymmetrical infiltrations due to pneumonia from COVID-19. But this is not entirely specific to COVID, because this is a feature of non-cardiogenic pulmonary edema in general. And this is an example of how you could use lung ultrasound to differentiate cardiogenic from non-cardiogenic pulmonary edema by looking at the pattern of B lines, the appearance of the pleura, the presence or absence of pleural effusion and the extent of pleural effusion, and the presence or absence of lung consolidations. So it's very important to look at B lines as a very sensitive marker of congestion, not only during exercise, but not only during rest, but also during exercise. And here is an example of using it as part of the stress assessment of patients in the echo lab. And in this, you could see the appearance of B lines during stress testing, whether exercise or pharmacological stress testing, far early before any X-ray changes, before symptoms, and before oxygenation declining. And my message here is to think of lung ultrasound as an extension of the echocardiographic assessment. And when you perform lung ultrasound and integrate it to your standard daily cardiac ultrasound, you enhance the ability to assess various cardiac disorders, specifically looking into patients with heart failure. And in this paper, we discussed the value of integrating lung ultrasound with echocardiography to identify different types of shock. You can use it in all types of shock, whether hypovolemic, obstructive, cardiogenic, or septic shock. But we should not be we should be careful and wary about the limitations of lung ultrasound to make sure that we are practicing it safely and appropriately. Lung ultrasound can miss pathologies deep within the lungs. Of course, it's a modality which requires training and experience, but the good news is that it has a steep learning curve. So you don't need much longer training to be competent in lung ultrasound, especially if you are a cardiologist who is well trained in echocardiography. It's an evolving field with more evidence, hopefully coming in the pipeline. And of course, the message is always to use the information obtained within the clinical context. We should not blindly follow on any of this information if it contradicts the other parameters seen at the bedside. And my final take-home message, I think and I believe that lung ultrasound should be part of the routine assessment of patients with echocardiography, not only at the acute care, but also at outpatient clinics. And we have many data to support this claim. I think that it should be used as an extension of bedside physical examination because it is performed very quickly in a very brief time. It has much higher sensitivity and specificity compared to chest X-ray. Always use it within the clinical context. And thank you very much for your attention.
Thank you, Dr. Hatem, for your elegant presentation. And do we have any questions?
تفضلي يا مرة تعليم.
I'd like to ask, where is its position in the guidelines when to do lung ultrasound in cardiac patient or in heart failure patient? Its position in guidelines.
Do you hear the question, Dr. Hatem?
Yeah. So the lung ultrasound position in the heart failure guidelines. Is that right?
So.
Is this the question? Did I hear it well?
Yeah.
Yes. So it is, as I mentioned, it is part of the guidelines. And now it has enough data to support using B lines, specifically B lines, as part of, I mean, you would not evaluate B lines without lung ultrasound. So assessing B lines is now an integral part of the guidelines for assessing patients with heart failure, whether for monitoring, it actually starting from the early assessment and diagnosis to monitoring, to therapy titration, to risk stratification and prognostication. And the availability of large amount of data bring us to a point of having this already part of the ESC guidelines of heart failure.
I'd like to thank Professor Hatem because he's focusing on very important topic, and he did a fantastic workshop at Cairo University Hospital, and I think we started to disseminate and implement for fellows to follow the recommendations to do bedside lung ultrasound in the ER for patients presenting with acute shortness of breath. I think it's practical and it's highly needed. So thank you very much for your help and your support, Hatem.
Thank you very much, Professor.
Thank you very much for your presentation. It's really very precise, and it is very encouraging for us. You mentioned that if you are mastering echocardiography, then you can do this lung scan easily. From your own point of view, if it's one echocardiographer, an expert echocardiographer, how many cases should he do to master lung scanning?
So it's a great question. Thank you, Professor, for it. So the recommendation now for people who has no experience with ultrasound, that they only need to do 30 cases of lung ultrasound to be accredited. So for someone who is fully experienced in lung ultrasound, I would think that half this number of cases would be more than enough, 10 to 15 cases. But of course, they will need to be supervised for the initial few cases. But as you said, having the experience and knowledge of echocardiography and ultrasound will make it much more easier and quicker for them to learn it.
Okay, thank you very much.
Thank you.
We are waiting for you to come in, and we would like you to participate in Ain Shams with us.
Yeah, the next time Hatem workshop
Is in Ain Shams, okay.
Yeah, Professor
It's a great pleasure.
Yeah.
Okay, it's our pleasure to have you with us. Thank you.
Thank you.
Any question? Thank you so much, Hatem, and looking forward to seeing you soon in person. Thank you very much.
Allah. Thank you, Professor Magdi.
Bye.
Bye-bye.
Next, we will talk about echo before and during percutaneous mitral valve repair by our colleague Mohammed Abdelghani from Azhar University.
Dear Professor Magdi Abdelhamid, thank you very much for holding such a unique meeting and for inviting me to contribute to this. I have a very hard task because I'm a speaker after very, very eminent speakers, Dr. Leon, then Dr. Delgado, and dear friend and superstar, Dr. Hatem. And if he is still online, مبروك على النيو لوك. مش عارف دي عمره بقى أكيد. My topic is, I'm not an echocardiographer as well. It's another complexity to my presentation. But those who are involved in the structural heart disease business have to learn more and more about echo. And since like 2015, I've been regularly in the echo lab trying to learn and to unify the language so that in the cath lab, myself and the echocardiographer, we have the same language and we understand each other. And when it comes to transcatheter mitral valve repair, especially the main topic today, which is transcatheter edge-to-edge repair, it's an echo arena. So it's really, I cannot separate the interventional part from the echo part in transcatheter edge-to-edge repair. I have no disclosures relevant to this presentation. And this is not just one interventionist who said this. This is what every experienced interventionist in this area would say, that the echocardiographer in mitral clip and or transcatheter edge-to-edge repair is at least as important as the operator. And because the spectrum is really exploding of the transcatheter options for transcatheter mitral valve repair, I will focus on the most extensively studied, most widely adopted, and the only FDA-approved technology, which is transcatheter edge-to-edge repair, especially with the mitral clip procedures with over 100 implantations to date. So Again, because I cannot really draw a line between echo and interventional part in this, we have to have a very short introduction to transcatheter edge-to-edge repair, or TEER technology and techniques. And for the mitral clip, there are several generations, and the most widely used today is the third generation device. And the third generation device has two platforms, the XTR, or the longer arm device, and the NTR with the shorter arm device. And one can tailor the choice between these two devices according to the extent of leaflet morphology and disease. For example, if you have a large valve with extensive disease that is central, then you may take the larger device or the longer device, which is the XTR. And on the other hand, if you have more commissural disease, which is smaller, and the annulus is a little bit smaller and the area is smaller, then you may take the smaller device. And now the fourth generation devices are being made available. They are under approval, and they add to the aforementioned variability in the length of the arm the W version of NT and XT. So we have now NTW and XTW with broader arm as well. So these are devices designed to address more extensive flail widths. And the more recent device or technology that is being under investigation now is the Pascal system from Edwards Lifesciences. And besides the arms, similar to the mitral clip, there is the spacer in between. And the concept is to fill the gap, so to literally fill the gap between the two leaflets. So besides pulling the leaflets next to each other, there is a spacer in the middle to fill the coaptation gap as well. The very first and very important task of echo in mitral clip is to assess the eligibility. And I can tell you that for many years, there has been strict adherence to the so-called Everest criteria, which was the trial that paved the way to the approval of the mitral clip technology. And it's a long list of criteria that had to be adhered to in every single patient. But this has become a history now, because over time, the concept of assessing patients' eligibility moved from strict adherence to the Everest criteria into the classification of patients into standard or simple cases and more complex, more or less off-label cases that still are doable. And the so-called classic case or ideal case would have absolutely no calcification in the grasping area, a central mitral regurgitation affecting A2P2, of course, absolutely no rheumatic affection, and a large mitral valve area to avoid mitral stenosis after a mitral clip, and a lengthy or generous posterior mitral leaflet to be adequately grasped, and not very extensive flail, either in terms of width or gap. The less suitable or less ideal scenarios include patients with some calcification in the grasping area, patients with relatively small mitral valve area, and patients with extensive disease, including rheumatic affection, perforation, or deep clefts or perforations. And these are just examples of how an ideal case would look like. The flail width should be small, not more than 15 millimeters. The flail gap shouldn't be more than 11 millimeters. And the so-called coaptation depth shouldn't be more than 11 millimeters. And the mitral valve area should be large, so that you avoid post-implantation or post-clipping mitral stenosis. But on the other hand, these are the less favorable counterparts in each of these, from each of these aspects, with very large flail width, very large flail gap, and a very deep coaptation and relatively small mitral valve area. So these have become like a continuum, a spectrum of cases, rather than black and white, yes and no, indicated, contraindicated. It become more like favorable and less favorable anatomies. And if we look at the contemporary TEER, real life registries document that over 50% of contemporary mitral clips are performed in mitral valve anatomy that is not fulfilling the Everest 2 criteria. So it's like 50-50. 50% of the patients have favorable anatomy and 50% have less favorable anatomy. And therefore, the concept of complex MR has evolved. So, these are just examples. It's an evolving concept. This refers to non-central MR or commissural MR, degenerative MR with wide flail gap, Barlow's disease with extensive prolapse, and even the introduction of MitraClip to very new spaces such as failed surgical mitral valve repair, acute mitral regurgitation, and even HCM with SAM, and even patients with aortic stenosis being sent to TAVI who would on the way undergo MitraClip procedures. And this is an example of a typical example of anatomies that used to be considered a contraindication to MitraClip in the past, with massive commissural mitral regurgitation. Nowadays, these lesions can be, in expert centers, be addressed with tailored MitraClip. And even more advanced is the concept of tailoring the device according to the anatomy. And I'm not going to go through this busy table, but again, it's just to emphasize that now we have multiple devices, and in centers with large volume of patients, the operators may even tailor the device according to the anatomy, addressing the very simple, straightforward lesions with the workhorse MitraClip, and moving to the more advanced or more dedicated devices, the more complex anatomy becomes. And the most recent evolution after many years of attempts is the secondary MR arena, because it has been a long journey trying to prove the MitraClip would be helpful in patients with secondary MR until the COAPT trial, which was the first randomized large-scale trial to prove that MitraClip may improve the outcome of patients with secondary MR. And therefore, the guidelines adopted the inclusion and exclusion criteria of COAPT trial as being the indications and the contraindications of MitraClip in secondary MR, a very long list. And to make this simple, I can just tell you that the key, what we have learned from COAPT trial, is that you need the combination of very severe MR and less severe LV dilatation and failure. And if you move to the other end of the spectrum with less severe MR and very severe LV dilatation and failure, then MitraClip will be possibly futile. Moving to the next or the second function of echo in the TER arena is defining the procedural target. And this is just an example of the importance in Barlow's disease, for example, with very extensive redundancy of the leaflets, that you should pick up the segments or even parts of the segments with the most severe prolapse as opposed to ballooning, and to define exactly where the origin of MR is. And then you can really hit your target. So on the first look, you may see a very extensive disease, but actually you can focus on a certain segment or segments where the real origin of mitral regurgitation is. And these are examples of how advanced echocardiography can very precisely define where the actual problem is. So it's not like mitral regurgitation. We should go much deeper. For example, on the left-hand side, you can see that these two jets, which eventually mix to look very severe, are actually a combination of a central secondary MR and another smaller primary MR due to perforation. So this will be handled in a very, very dedicated manner if we are planning to send this patient for MitraClip. And these are another examples of that. MR has very different morphologies, very different phenotypes, and 3D echo can be very valuable in defining this very central discrete regurgitation, this wide secondary MR regurgitation in the B panel, and these two discrete regurgitations, and the other very localized commissural regurgitation in panel D. Moving to the procedure itself, it's almost 60% echo and 40% catheterization. And using the advanced echo techniques makes a big difference. And I will just mention 3 examples. The modern X-plane with malleable combination of projections, so you don't have to have 2 perpendicular views. You can modify the angle between the 2 views. The live 3D multiplanar reconstruction, so it's almost a live CT scan. And of course, trans-elimination and tissue transparency, which will give you even more details like the examples I've just shown. And moving through the steps of the procedure, every single step can be improved and optimized using echo guidance. And the concept of site-specific transeptal puncture has become established now. It's not just in the fossa ovalis. You should hit the right point in order to facilitate your procedure. And in general, in mitral clip procedures, we go to the superior posterior sector of the fossa ovalis, and we should achieve a certain height. Otherwise, your procedure will become almost impossible. So the general rules are to hit the superior posterior mid aspect of the fossa ovalis and to maintain or secure a height from the mitral annular plane of at least 4 centimeters. Of course, if you have primary disease, you may need a higher puncture, and if you are addressing secondary MR, then the coaptation level is even lower towards the LV apex, and then the transeptal puncture may be a little bit lower. If you are targeting a lateral commissural disease, then you should have relatively low puncture, and if you are addressing a medial commissural disease, then your puncture should be higher. This is an example of what I've mentioned with new X-plane imaging with unlimited plane combinations. So you can have the bicaval securing the anterior, superior, inferior orientation combined with the short axis, which is not at 90 degrees with the bicaval, to guide your anterior posterior orientation. The next step is clip delivery and deployment, and the clip steering and positioning has certain goals. The first and most important is to align the open arms of the clip perpendicular to the coaptation line. This is like 90 degrees when you are addressing a central regurgitation, A2, P2. But if you move to a commissural disease, then you have to have some inclination so that you maintain this perpendicularity. Of course, you should also address the origin of the regurgitation, and you maintain safety by not hitting the lateral LA wall or being entangled in the mitral valve submitral apparatus. This is an example of the correct orientation of the open arms of the clip. Should be perpendicular to the coaptation line, and this is how it should look like. On the right-hand side, it's perpendicular to the coaptation line. On the left-hand side, it's not very accurate. And one can even try to cross the mitral valve at the origin of the mitral valve regurgitation. Again, after you pass the valve into the LV, you can recheck your orientation. On the right-hand side, you can see this is an LV perspective, but of course the gain is being reduced so that you can see through the submitral valve apparatus, but you should keep this perpendicularity throughout the procedure. Then the grasping process, and again, this is entirely guided by echocardiography, and it's probably the most sensitive part of the procedure. You grasp the leaflets, the anterior and posterior simultaneously, and by the way, the more recent generation, the 4th generation of the mitral clip, allows for independent grasping of the leaflets, so that you can focus on the anterior mitral leaflet, and then you move to the posterior leaflet, and so forth. Finally, the post-deployment assessment, a long list of checklists. Actually, you check for basically, are you satisfied with the result or not? You need another clip or not? And if there is a complication, and just 3 items to be double-checked that you have confirmation of adequate leaflet grasping, and these are 2 signs of adequate leaflet grasping, the so-called leaflet tension. The leaflets are pulled, and this means they are really grasped, and the other sign, which is symmetrical triangles, meaning that both leaflets are adequately and equally grasped. Evaluation of mitral regurgitation after mitral clip, I'm almost done, by the way. It's like 60 seconds. The assessment of residual MR is really complicated. You can see here, these are 4 examples of residual MR, 3 jets, 2 jets, 2 jets, and even 5 jets after the implantation of 3 clips. So these are usually multiple jets that may merge, leading to overestimation. And PISA is therefore not reliable in this setting. There is a guideline to guide our assessment of residual MR. It's a very basic table, so I'm moved to this more practical approach. It's a collective, multi-modality or multi-parameter approach. So if there is significant reduction of the jet area, you can see, and there is a reduction of the vena contracta area on 3D, and there is improvement of the pulmonary venous flow with blunting of the reversal, these are signs that your mitral regurgitation has significantly improved, and the role of 3D vena contracta area is really evolving. So you trace the vena contracta area of each jet separately, and then you add these areas, and finally you make sure that there is no significant residual MS after clipping, and again you take 3D, advantage of 3D, and you trace the separate orifices, because now you have at least two orifices, and you trace each separately, and you add both to each other. So my take-home message is that the eligibility for mitral clip or TEER has evolved from very strict adherence to the Everest criteria to the concept of complex MR, to the more advanced concept of tailored device choice, and finally to the secondary MR arena. The second message is that in-depth analysis of mitral valve anatomy and morphology is key to procedural success. As I've mentioned, you should hit the right target. Using the full echo potentials, the advanced echo techniques makes the procedure simpler, safer, swifter, and more effective. And finally, the mitral valve orifice anatomy is markedly distorted after the procedure, and therefore post-clip assessment of MR and mitral stenosis requires the integration of multiple parameters together, as well as the use of dedicated parameters dedicated for this setting. And thank you very much for your attention.
Thank you, Professor Abdelghany. Thank you very much. You made things very simple, as if it's at the tip of our fingers, which is not actually the case. Now, after all what you said, which patient I will tell him, no, you're not fit for the clip, please? The answer, I always answer these questions in the transcatheter valve interventions for valvular disease from 2 perspectives, clinical, anatomical. So it's always like that. So from a clinical standpoint, the guidelines support mitral clip or TEER only patients who do not have surgical options. So the first question is, does the patient have a surgical option or not? I'm talking about primary MR, organic MR. So if the patient already has a surgical option, it's done. He or she should be sent to surgery. The second question or answer is from an anatomical point of view. There is actually almost no contraindication to mitral clip in current practice, except for massive leaflet calcification or very small area. Because if you start up with the combination of rheumatic heart disease and small area, you will end up with tight mitral stenosis, which doesn't make any sense. So you will eliminate mitral regurgitation, but will end up with even higher V wave in the left atrium because of the mitral stenosis you have induced. So a patient with a surgical option should be sent to surgery, especially if he or she has a good chance of durable mitral valve repair, and a patient with extensive leaflet calcification or small mitral valve, and by small I mean smaller than 3 centimeters square. So it's a standard contraindication to mitral clip. An area of smaller than 3 centimeters square is a contraindication to mitral clip. Otherwise, it depends on the expertise of the center. I just want the audience to hear that there is a contraindication. Not everyone is going to be subjected to the clipping.
Of course. I have to sell. That's why I made
you're
it.
You're selling
I made it look even brighter.
Easier, yes.
Thank you so much, Dr. Mohammed. Excellent presentation.
Thank you.
طبعا secondary MR or functional is totally different.
It's a different story.
Yes, guideline directed medical therapy, CRT, and then class 2A.
Is a different story.
Age to age.
Secondary MR has, it's really ironic because it's been long road until secondary MR has been approved to be treated with TER, but once it's approved, it has a higher level of recommendation because these patients don't have surgical options most of the time. Over the years, surgery for secondary MR proved systematically to be futile. So several randomized trials tried to show that you do CABG and you do mitral repair surgically and then you improve the outcomes. No, it's not the case actually. But with the COAPT trial, there is a hope for these patients with severe secondary MR who are still symptomatic in spite of optimal medical treatment that TER may improve their prognosis, and this is why the threshold is lower. Let me rephrase this. The threshold to use MitraClip based on current evidence is lower for secondary as compared with primary MR. So a patient with secondary MR, I would think of MitraClip even earlier in his course because of the evidence and the lack of surgical options in most of the cases.
But we have to see the outcome after using guideline-directed medical therapy because the new drugs have a reverse remodeling effect, which decrease mitral regurgitation, and actually medical treatment is associated with 40% reduction in secondary MR severity.
And device therapy as well.
Yes. So
and
before
if there is an
considering-
indication for device therapy, of course. After we exhaust all these options, MitraClip should be our second step.
Great. Any question?
Thanks so much for your excellent presentation, Dr. Mohammed. I want to ask for patients with infective endocarditis and healed vegetations or mitral aneurysm, and they are left by perforation in the leaflets. They can go for mitral clip and avoid surgery, especially if they are young and no decompensation, ventricle is good, and all the other comorbidities is okay. Yeah.
Okay. So any suspicion of active endocarditis is an absolute contraindication to any transcatheter therapy. This applies to TAVI. Mortality is 50% if the patient develops post-TAVI endocarditis. This applies to paravalvular leaks, and this is the very first and the most important step in PVL closure percutaneously is to be 100% sure that there is no active endocarditis in the background. The same applies to MitraClip. The first step is to exclude any residual activity. So there is absolutely no residual inflammation, no active infection. And after we make sure that there is no residual infection, it becomes a complex MR. It's a complex MR with a perforation. Yes. So it's an off-label indication. It's an off-label indication. Again, only send this patient to TER if he or she does not have surgical options. Otherwise, it will be less durable,
more appropriate.
Less durable, and of course, it will be a complex procedure because perforation is a really tough job to address.
Okay, thank you.
I have a comment for this. In our cath lab, we do close perforations of the mitral valve by ASD devices. So we did so, but on condition, again, I'm not selling the procedure. If it has some restrictions, it shouldn't be very towards the base of the leaflet, no matter whether it's anterior or posterior mitral leaflet, it can be done, but we have to do our measurements. Thank you very much. We thank all the speakers and the chairperson and the coach. Thank you. You have to close this.
Thank you.